Okay, welcome to the CNSAC meeting today on August 27th. We will do item number 1.0, call to order, roll call, and establishment of quorum. So Jessica Lightcap present, Elizabeth Scruth,
Present.
Alyssa Brown present.
Carrie Krogan,
Present.
and then Marilyn Ababio.
Present.
Okay, so that is establishment of quorum, and we'd like to do a brief introduction of our two members. Lizzie, would you like to go first?
Oh, sure. I'm Lizzie Scruth. My day job is with Kaiser Permanente as the Executive Director for Northern California for the Clinical Quality Programs, Data Analytics, and Telecritical Care. And my previous experience on a board was I served 8 years on the American Association of Critical Care Nurses Certification Board, 2 of them as chair and vice chair, and approving the CNS exams that they audicate. Thank you.
Okay, thank you. And Marilyn?
I'm Marilyn Ababio, known as a complex systems manager. I retired from Alameda County Healthcare Services Agency, where I directed a program for seniors who are managing a chronic disease with a serious illness or facing end of life. I was referred to this committee by a co-member. I'm sitting on the UCLA Ethics Committee right now. And I am also the managing director of an advanced care planning consulting firm called Comfort Homesake. Happy to be on the committee, happy to meet each of you.
Thank you.
Welcome, both of you guys.
Okay, closing the window, please. Okay, item number 2.0, general instructions for the format of a telehealth conference meeting.
Good afternoon. This is the BRN moderator. I will be moderating the meeting. To facilitate public comment, we will be utilizing the WebEx question and answer feature. It is now known as Slido. When the committee reaches a point in the agenda at which public comment is appropriate, the question and answer feature will be turned on, and members of the public can indicate that they would like to make a comment by inserting the phrase, "I would like to make a comment," in the question box, which is typically in the lower right of your screen. We will also query our in-person meeting, meeting room in BRN HQ. Currently, I am told there's nobody there. I will then call on the individual and unmute their microphone. The individual will have 2 minutes to make their comments. I will not give a warning as your time approaches. I will mute your microphone and will announce that your time has exceeded the time allotted. I will then proceed to the next member of the public who has a comment. Please note that the question and answer feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. When your turn comes, you will be prompted to unmute. If your question can be answered, the committee will respond accordingly. When making your comments, speak about anything you believe is important for the members to know. Remember, committee members cannot address any item not on the agenda. Items not on the agenda at that moment, items that you would like to add to a future meeting, or items that will be discussed later on in the agenda will be discussed at their correct times during the meeting. I will provide a brief reminder of this approach at the start of each public comment item. Finally, when committee members or BRN staff are not speaking, I would like to remind them to mute their microphone. If I detect background noise during the meeting as a result of unmuted microphones, I will mute your microphone automatically.
Thank you, Mark. Moving on to item 3.0, public comments for items not on the agenda and items for future agendas. So I'd like to move this out to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should to see how they should type in their request for a comment. Wrong button, sorry. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Lightcap, there are no public requests for comments on the WebEx/Slido. We have no in-person representation in our meeting room in BRN HQ. Would you like me to close this window?
Yes, please.
Thank you.
Okay, moving on to item 4.0, review and vote on whether to approve previous meetings minutes. Item number 4.1, the meeting minutes were from January 16th, 2025. I'd like to do a roll call out to approve the minutes.
I move to approve the minutes. It's Alyssa Brown.
I'll second the minutes. Carrie Grogan.
Okay, thank you. And now we can move out to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Lightcap, there are no public requests for comments on the WebEx/Slido. Oh, somebody just popped in. Hold on one second. Terry Aries would like to make a comment. 1 second, please. Terry, go ahead.
Okay, thank you. I'm having a little trouble navigating here. I am Terry Aris. I am the director of the Clinical Nurse Specialist Program at Cal State Dominguez Hills. And I'm not sure if my comments are appropriate at this time or later as you're talking about the regulation. But after reading the minutes, I did have some concerns about some of the discussions that occurred at the last meeting, particularly regarding what looks to be the desire to not adopt the APRN consensus and the LACE guidelines, where licensure, certification, accreditation, and education are aligned within the particular populations for the CNS. I am supportive of certainly of making sure that people who have been educated in the past before all of these things changed are brought into the fold and have a pathway for licensure within the state as a CNS. But I think going forward into the future, from the point in time when the regulation, is on the books, that we should be making sure that we are aligning with those national regulations and that there isn't drift from that. So particularly some of the things that I noticed in the minutes had to do with a discussion of the CNS being able to practice in any area where they wanted to. And while that discussion could have been thought of as an actual setting, which would be fine, it did not it didn't specify that one would have to stay within their population. And I believe even Loretta talked about competencies. And so, nationally, the way that we do that when we want to expand our populations is we do a postmaster's certificate program. And all of these programs are accredited. And the accreditation process, I did check on it from all 3 accreditors, include competencies, the national standards for the CNS, and so on. So I think that's the bulk of my comment at this point.
Thank you, Terry. If you can do me a favor and let me know where that concerning part, if you have a page number on the meeting minutes, that would be, so I can take a look at that. Just to make sure real quick that it wasn't misquoted or misunderstood. The one thing that I do want to make sure that everybody is aware of, our board, I believe in 2008, right after the consensus model was released, adopted the consensus model. So we are, our board has directed us to align with the consensus model. That is not something that we are trying to drift away from. So if that was something that you believe showed up in the minutes, I want to make sure that I go back and listen to the conversation again and make sure that we captured that correctly. You were correct in the fact that there was conversation about how clinical nurse specialists that do not have a current exam offered for their certification can maintain their ability to keep their license and continue to work. So we tried to provide some guidance with that. The one thing that I think that you're referring to around competency is right now, the CNS has the scope of practice of an RN, even though they are an APRN. Their scope of practice is not greater than that of an RN currently in the state of California. And because the CNS only has the scope of practice of an RN in our state, RNs are not limited by a population focus. And so it is competency based. So even though we want to align with the consensus model, even though we would, this committee and CNS practice wants to work at their level of education and training, that is not something that is supported currently in statute in California. And so at this moment, a CNS can work in any area that they choose to, only because their scope of practice is that of the same as what an RN has in California. So as potential legislation is introduced, as potential changes to the statute come forward, and a advanced practice scope of practice has been attached to the clinical nurse specialist, the request at that point, as that moves through, would be to align with what our board had requested, and that is to align with the APR consensus model, where if you are a neonatal CNS, that you are educated as a neonatal CNS, that you have passed the neonatal CNS national boards, and the area that you provide that services is with the neonatal population focus. So that's just to clarify that. And again, if you could respond to where specifically in the minutes that is, I would like to take a look at that.
Sure, I'd be happy to send a highlighted copy to you. I don't have them handy this second, but I'll pull them up.
That's okay. And then Reza, just for process, my question is if we adopt them today with no edits and we learn in the future that there might need to be a change that happens, we just bring it back to the next CNS meeting with those changes and we can update that. Is that accurate?
Couple things what you said, I think, is you can adopt them today and amend them later if necessary. That's a possibility. Of course, the obvious alternative is to just defer on it, or you could adopt them today with discretion to make a necessary amendment. We usually do that with discretion to make non-substantive amendments, but we can kind of expand that little carve out to address this if it's determined to be necessary, whatever way the committee wants to go. The other thing I just wanted to mention, I don't know for sure if this is the exact language, but I just did a quick search in the materials, and consensus model, just the word consensus, only shows up on page 11. It's, yeah, page 11 of the PDF. So I don't know if that's something you wanted to take a quick look at now or offline.
It does look like that is the conversation around that, yes, is on page 10 and 11. Perfect, thank you. So Jessica, it says Jessica Lightcap asked about draft regulations, section 1497. It says the CNS may practice in any clinical practice setting or area regardless of category of certification by one of the member organizations. She would like more clarification on this. Doesn't mean that a paid CNS could practice as an adult. And so that's where that conversation does start. And then it says that I at the bottom say a general RN coordinator, especially if they are competent. We err on the side of being competency based. The BRN does not define individual competencies, et cetera. So I can see where that is. I can elaborate more on that to clarify that using more of the language I used today, that the current scope of practice for a CNS in our state is equal to that of an RN. And therefore, that's not something that is, they are not only required to work within their education and training and national certification. When legislation is passed in the future that addresses an expanded APRN scope of practice, I assure you that would be part of the consideration of that legislation as it moves through. So we would then at that point align with the consensus model. So I can update that. Yes, Alyssa.
May I change my motion then?
Yeah, you can do what you need to do here.
I move to accept the minutes pending the necessary amendments that may need to be made.
Specifically on page 10 and 11 around this discussion and the consensus model and competency-based practice area.
Yes.
Perfect. Can do. We can update the second on that one.
I second that with the same as Alyssa. Thank you.
And
Thank you for
Terry-
bringing that up, Terry.
Yeah, and Terry, is there anything more or any additional clarification that you'll need?
Well, I had some more questions and thoughts, but again, I'm not sure if now is the time to bring these up or if it's later.
If it's about
on
the
the
meeting
agenda.
minutes,
No.
this is the right time. If it's about proposed regulation, we'll go to that section and have you hold off.
Okay, I'll wait then.
Thank you. Appreciate it.
Thank you. We have no other requests on the Slido, and we have no in-person representation at BRN HQ. Would you like me to close this window?
Yes, please. Thank you.
Thank you.
Can we get this slide advanced to agenda item 5? Oh, we have to roll call vote.
Yeah, call for the vote.
That's
Okay.
us. Sorry.
Yep, sorry. Roll call vote. Carrie?
Yes. Approve. Aye. What am I supposed to say? Okay. Sorry.
Alyssa?
Yes.
Okay.
Elizabeth?
Yes.
Marilyn?
Yes.
Okay. And me, yes. Jessica. Okay. All right, moving on to item number 5.0, information
One.
only.
1 second, Jessica. Elizabeth can vote on the minutes. She can either abstain or she can vote if she reviewed the last webcast as it's recorded, and she believes that it'd be accurate as that. But it's up to you, Elizabeth, or Lizzie, sorry, how you would wish to vote right now, either abstain or if you've read and sorry, if you've watched and read the minutes, you could support it.
Abstain. Thank you.
Thank you.
Okay. Moving on to item 5.0, information only, report from the BRN executive officer regarding updates on activities which may impact clinical nurse specialists.
Okay, so this is a standing agenda item, and I can let you know, honestly, there hasn't really been much movement at all in this realm. There's nothing new that has been brought to my attention of anything that is affecting or impacting the role of the clinical nurse specialist to date. So a very short and sweet information only update at this point. So, but if you guys have questions or if you guys heard anything that you want to make me aware of, please let me know, and I could expand on that if I have that information. Any discussion? No? Okay, so this is information only, no vote needed. Board moderator, if you want to open up for public comment, please.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Mary Lawanson Nichols would like to make a comment. 1 second, please. Mary, on your computer, if you have any windows open, you have to minimize and find the little one that says unmute me. There you are.
Okay, so sorry. Work computer does not like WebEx, so please forgive me. My name is Mary Lamont Nichols, and I'm part of the California Association of Clinical Nurse Specialists. One of the things I just wanted to just check with the board is that there's been activity through the California State Organization around clinical nurse specialists. I wanted to just make sure when this could go ahead and be heard. I didn't want to go ahead and interrupt. Just when it's available, I'm on the call. Thank you so much.
Wonderful. So Mary, that you are agenda item. Sorry, we go 10.0. And so that would be probably close to our last agenda item. So right before we go into, no, it's not. You are just agenda item 10.0. It's not the last. And
Okay.
so we will let you know. And at that point, we will actually elevate you to be a panelist. And
Oh
so
my,
at
okay.
that point, you'll be up to a panelist. You'll be able to speak freely on what's going on, and we'll have an interaction. You will not be limited by time necessarily. Now, if you want to take an hour, that's usually what I do, and 2 of us won't work.
Oh no, I have been told strictly 5 minutes. That's it. So thank you so much. I just wanted to just go ahead and make myself heard. I'll put myself back on mute until you call on me.
Sounds great. Thank you, Mary, and thank you for showing up.
Thank you for your comment. Committee Chair Lightcap, there are no other public requests for comments on the WebEx/Lido, and we have no in-person representation in our location in BRN HQ. Would you like me to close this window?
Yes, please. Thanks. Okay, moving on to item number 7.0.
And then
I think we 6.0.
Oh yeah. 6.0, meeting dates.
Yep.
There we go.
And then just so you know, Jessica, when we do get to 7.0, I will take that because for that moment, you are no longer the chair.
Okay. Okay, so item number 6.0, discussion and possible action regarding meeting dates for 2026.
So in your materials, starting on page 14 is the agenda item summary, and the dates that are proposed are on the 15th, on page 15, sorry. We are looking at April 7th, 2026 and October 6th, 2026. Today, the CRNA Advisory Committee did vote to adopt those days. So if it is possible that you guys could adopt the same days, that would be fantastic. If not, we are totally willing to work within that. Currently, there's a bill moving through the legislative session. We do anticipate it to be passed and implemented by January, but anything can happen. That is a bill that was put forward by DCA that allows for the flexibility in Bagley-Keene that our advisory committees continue to meet virtually. If for some reason that bill does not pass, then these committee meetings would be required to be held in person. We would have a location. We secure locations north and south throughout California. And so just keep that in mind. We will know in about a month or so if that provision stands. And you guys can maintain this virtual process, but if not, we would have to be available to travel or notify a public location in your area if you are not able to travel. So we're looking at April 7th and October 6th.
Those are okay with me.
Yep, they're okay with me as well.
Okay,
Carrie.
Same.
same with you. And how does it look for Lizzie and Marilyn?
It's fine by me. Thank you.
Those dates are so far out. It's fine.
That's fantastic. I love
Yeah.
to hear that. We do know that sometimes things come up, so we do have the ability to move them around if we do need to, but it would be nice to keep them and make the plan moving forward for that. So at this point, I would request a motion to approve the dates in a second. Carrie.
1 second, sorry. Will we be emailed out when you know the response of the Bagley-Keene thing? Will you let us know?
A phone call would be best because then you can hear us screaming and cheering. But yes,
Oh.
we will send an email out. Yeah, we'll let you know if it's able to maintain the remote aspect.
Okay, I move to approve those dates. Alyssa?
And I second.
So we'll go to public comment, or sorry, Jessica. That's public.
Yes.
April.
Move out to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Lightcap, there are no public requests for comments on the WebEx/Slido. We have no in-person representation in our public location in BRN HQ. Would you like me to close this window?
Yes, please. Thanks. And then roll call vote. Alyssa,
Yes.
Carrie,
Yes.
Marilyn,
Yes.
Lizzie,
Yes.
okay, Jessica, yes. Okay, moving on to Loretta. You are muted.
That's awesome. Thank you. Usually I'm the one that has to say that, so thank you for that. So agenda item 7.0, you'll find the material starting on page 17. Our board does board president and vice president vote yearly. That is required in statute. So when we created the charters for each of our advisory committees, we decided to carry that through. So with that, we do an annual election of our vice chair and our chair. The vice chair serves in the role that the chair does when they are not here. And we're here to assist you at any of that, with any of those items that may come up. So at this point, we do have Jessica, I believe you're the chair, and our vice chair is excuse me, Alyssa. So at this point, you guys could re-elect the same chair and vice chair, or you guys could make a kind of appointment or a nomination of somebody else to go into those roles. You can nominate yourself as well. So the first one that we're going to go through is the nomination of the chair for the CNS Advisory Committee. Do we have a nomination for the chair?
Can we have discussion, or do we just have to nominate?
You can have discussion. Yeah, it's your agenda item. Go for it.
Chair Lightcap, you have done a wonderful job, but I just want to make sure, like, do you want to continue to do it, or, you know, I don't want to nominate you and you be like, oh, I was hoping to step down, you know, so just kind of wanted to have that discussion.
I would love to continue. I think it's been a really great learning experience, especially with Alyssa as the vice chair, helping me through everything. She's so knowledgeable. So,
Thank you.
thank you.
I would support Jessica as well.
This is Marilyn Ababio. I would just like a little summary of the qualifications for these two positions.
We have no qualifications required. You're on this committee. So if as being part of this committee, you decide that it's something that you want to do, you have every ability to do that. It could be any of the CNS members. It could also be the public member if they want to serve as chair or vice chair. So we are free to nominate anybody at this point. With that nomination, we usually do the check, Carrie, and this is probably your first time with this, is if you would have just nominated Jessica, I would have then put Jessica on the spot and said, is that something you want to do to continue? And then we ask if there are any more nominations. If there are multiple nominations, then there's discussion around what the group wants to do. And we do a majority vote at that point for the chair or vice chair position. So hopefully that answers your questions, but honestly, we have no requirements other than the willingness to do the role. That's really it, and that you're on this committee.
Thank you.
You're
And
welcome.
I would be willing to co-chair, to vice chair again.
Okay.
If
We do have a
people
nomination
want me
for,
to.
that's okay. I mean, you just nominated yourself, Alyssa.
Oh,
So
okay.
I'm good with that. We do have a nomination for Jessica and Alyssa to continue as chair and vice chair, but we are open to any other nominations if there are others out there.
This is Marilyn again. I just trying to get grounded. So could both Jessica and Alyssa just, give a 1 minute or 2 minute summary of their background, or, how they came to want to be in this role?
Sure. I could go first. So my name's Jess Lightcap. I am a clinical nurse specialist in pediatrics. I work at UCSF, Benioff Children's Hospital, Oakland, in the orthopedics department there. I spent my beginning of my career as an inpatient nurse, and now as a CNS for the past 6-7 years. I've been doing a lot of the program development for our orthopedic pediatric patients at UCSF. And so when I'm really passionate about CNS practice in California, because I'm not originally from California. And so when I was first exposed to CNS practice, it was in a different state that has, different rules that CNSs follow and different, practicing at full practice authority and scope of practice. And so I'm very passionate about that. That's one of the reasons why I applied to be in this position on the advisory committee, because I wanted to help our CNSs across the state improve and practice at their full scope of, what we're trained to do. I'm also really passionate about helping our CNS students grow and learn, and I've precepted probably like 7 or 8 CNS students since I became a CNS. And I really love teaching them. I love being their support for when they're going through their board certification process and trying to figure out, what avenue they want to go down. I've recently just started to become more involved with the CACNS group as well, and really loved the meeting that we had a couple weeks ago with the outreach and stuff that we've been doing. And so, yeah, I'm definitely like, I really love this group. I feel like we're working really well together and trying to make some big changes for California and nursing care within the state. Thank you.
You
Thanks,
sound well qualified, and thank you for leading us.
Yes, no, it's been really fun and definitely a learning curve, especially holding the meetings and knowing what to say or trying to know what to say. But it's been really fun. I really liked it.
And you want to hear from me too. Alyssa Brown, and I've been a clinical nurse specialist since 1969. So I've been in the role for a long, long time. I actually started some clinical nurse specialist group both in Chicago and in California. And I actually was on the ANA, Council of Clinical Nurse Specialists, a long, long time. So I'm very passionate about the role. I was president of a group of psych mental health CNSs in California, and we put together a summit. Actually, for about 4 or 5 years, we had an APRN summit so that we could, together with all APRNs, toward full practice authority. And so I'm really excited about where we're at right now. Again, I'm just passionate about the role. I have absolutely loved my career. My last full-time job was at the VA, almost 40 years. I ran a geriatric psychiatry interdisciplinary clinic and did caregiver support groups for 30 years, and I co-chaired our ethics committee for. I'm still volunteering at the VA on the ethics committee and I'm volunteering at Kaiser, and I'm doing some teaching and consulting of CNSs and in care, especially geriatric psychiatry and ethics and psychiatry in general.
Wow, thank you, Alyssa.
And it's been a pleasure to work with this group. I was also on the first advisory committee of CNSs back in 1998. We did the Titling Act. Thank you.
Thank you. So do we have a motion to accept the nominations for Jessica as chair and Alyssa as vice chair?
I motion.
We have a second.
I second.
Thank you. Seeing that, we'll go out to public comment. Board moderator?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in the request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment."
Who made the motion?
The motion
I
was
did.
Carrie, and
Carrie.
the second was Marilyn.
Mary Lewanson Nichols would like to make a comment. 1 second, please.
I just wanted to go ahead and comment. I'm so happy to hear that Jessica is staying on and Alyssa is also staying on in their position. Glad to be having such passionate CNSs helping to lead our colleagues. Thank you.
Thank you for your comment. Board EO Melby, there are no other public requests for comments on the WebEx or Slido. We have no in-person representation in our meeting room in BRN HQ. Would you like me to close this window?
Yes, please. And so at this point, Jessica, it's back to you. You can take a roll call vote on this and you get to maintain your position as chair.
Okay, thank you. All right, let's do a roll call vote. Alyssa,
Yes.
Carrie,
Yes.
Marilyn,
Yes.
Elizabeth.
Yes.
Okay, and then Jessica, yes. All right, next item on the agenda, please. Item number 8.0, discussion and possible action, a report from the two CNSAC committees, public engagement and website, and regulations. Okay, so regulations, do you want to go first?
Real quick, Jessica, we do have a regulations agenda item later. So if that regulation subcommittee wants to defer till then, you absolutely can. And then you can just do a report out from the website, but it's completely up to you.
Yeah, I was going to say refer to agenda item 11.
Yeah.
Okay, great. So I can report out on public engagement and website. So now that we have, one thing I would like to ask is, now that we have Elizabeth and Marilyn on in our group, I'd love to have a partner in looking at public engagement and website together with someone, because I haven't had a partner. So I'd love to have someone to review this stuff with.
This is Marilyn. I have a background in public engagement, so I'd be happy to assist.
Great, thank you.
Thank you, Marilyn.
Fantastic. Jessica, did you want to report out on any stuff that you've been working on or?
Yes. So I've gone through the schools on the website that have CNS programs and made a couple of suggestions and updates to that graph. And I also want to highlight that there's been some changes to the first page of the website, where you can actually go under advanced practice, and clinical nurse specialists are there. And so it's a little bit of an easier way to navigate. And yeah, more to come. Anything you want to add for that, Loretta?
I was actually gonna screen share really quick, so I'm just trying
Oh,
to.
good. That'd be great.
So you guys can see that. So what I'm gonna do is just start from the beginning. So give me 1 second to share and I'll pull up just a blank internet page. Just gotta find it here. There we go. Stop sharing content. So you can steal that. Okay, are you guys able to see my just basic landing page? Is it showing through?
Not yet.
Not yet?
Oh, there you go. Mhm.
Okay, great.
See the PowerPoint?
So
Just
still just
the
the
PowerPoint?
PowerPoint?
Oh, yep.
Okay. So then at this point, if you just type in rn.ca.gov, it takes you to our homepage. If you scroll down on our homepage, right here in the middle section right here where it says underneath, welcome to Board of Registered Nursing, we have our Nurse Practice Act, Advanced Practice Information, General Practice Information. But then over here on the right is a link to each one of our advanced practice RNs. You can click on regulations here, FAQs, RN careers. But if you stay on what the landing page comes to as practice, you can then click on clinical nurse specialist here. Once you click on that, it takes you to this landing page. It gives a very brief explanation of what a CNS is. It links you in the resource sections to our clinical nurse specialist statutory language, then because you guys currently function under a RN scope of practice, Business Professional Code 2725 is the RN scope of practice. There was an update during COVID for the CARES Act that allowed for CNSs to do some activities. And so we do have a link to that for you as well. And then related links is the certification of a clinical nurse specialist, CNS national certification. These are kind of all on our website. You can click on them and it'll take you off. Oops, sorry, I just clicked out of that on accident. And how to apply, CNS programs, the CNS psychiatric mental health listing for RNs. And then this bottom link here goes right to this ad hoc meeting, tells you who serves on the committee, what the subcommittees are, and who are serving as on the subcommittees. We do have a historical document on here as well. It was a survey done in 2010. It is definitely 15 years old, but it's good information. If we do some more surveys and stuff, we can add to here. And these other resources right here are links out to CACNS, your California Association of Clinical Nurse Specialists, your National Association of Clinical Nurse Specialists, the APRN consensus model by National Council of State Boards of Nursing, which was talked earlier on public comment around our meeting minutes. And then the National Council of State Boards of Nursing also has a map showing where independent practice occurs and where prescribing occurs throughout the United States. If you are interested in seeing that, what I can do at this point is click on this. And let's see if it will open in there. And so you can see on this map that California is grayed out. It said no data not recognized in APRN. That's not accurate. I will have to reach out to them and update that, because you are recognized as an APRN, but it should be blue and say that you're not independent. And so I will get that updated, but you can see all of the light blue states are where a CNS currently has independent practice. Additionally, I can click on the prescribing map. And again, you will see here, and this one is accurate. It does say no prescribing authority. It is a light blue state. Your very, very light blue, pale blue, there we go. So your other light blue states are all independent. So Washington, Oregon, Nevada, New Mexico, those are states with CNSs, and they are able to prescribe in those states. The dark blue states says that you can prescribe, but that you're not independent in your prescribing abilities in those dark blue states. So this here, it's good information. It's always stuff that I try to share out with our legislators if they have questions or comments, because they want to know where California stands in relation to the nation. This is a good resources for that kind of information. So at this point, I will stop sharing. And that's the section of the website that Jessica is referring to in the website update. If you guys notice anything on the web that is outdated, that would be helpful, that needs to be updated, please reach out and let us know. We are aware of the schools. Those haven't been updated yet, but that is on our radar now. And so we will be working to get that updated.
It looks much user-friendly, more user-friendly. Thank you.
Thank you. It's not super attention grabbing because we are a state entity. I would love to put a bunch of visual representations and videos and all that kind of stuff on there, but we're not quite there yet. But to have it in one location, that is helpful.
Thank you.
Thank you.
Okay, and let's move out to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. Committee Chair Lightcap, there are no public requests for comments on the WebEx/Slido. We have no in-person representation in our BRN location in BRN HQ. Would you like me to close this window?
Yes, thanks. Okay. Do we do a roll call vote on the last one? On number 8, do we have to do a roll call vote?
It was presented as information only, so there's no reason, there was nothing for them to
Okay.
accept. So no, you do not
Okay.
have to do that.
Okay. Moving on to item number 9.0, information only, an overview of the 2026 BRN sunset review process.
Thank you for that. So starting on page 21 is the agenda item summary that covers kind of what the sunset review process is and why we have it. And then there are some resources on there as well. If you wanted to take some time and read our prior sunset report, background papers, and our response. So different from private sector, in my background is private sector. So I've been part of this board since 2014 and became the executive officer in 2020. And in 2021, we had to start, or sorry, even before that, 2020, I believe, we had to start writing our sunset review report. So what happens with state agencies like our board is that comes underneath the Department of Consumer Affairs is we are only here in our 9-member board is what I'm talking about, just to be very, very clear. So we have the Board of Registered Nursing, which is staff that, and I'm one of them. And we process applications, licensing, enforcement, clinical, I'm sorry, not clinical, but scope of practices established, et cetera. But in addition to that, we have a 9-member board that's made up of 5 RNs and 4 public members. That board is only allowed to continue as long as the legislator says it can continue. So about 4 years, and I can tell you that hasn't been the history of BRN. So we did a 1-year sunset and then a 4-year sunset. But on average, about every 4 years, a bill is presented to extend that 9-member board. So in 2022 was our last time they looked at us. And at the end of that legislative session, they extended us for 7 years. That extension sunset January 1, 2027. So in the year preceding that, our hope is that a member of the legislature would graciously pick up a bill that says we want the BRN the 9-member board of the BRN to continue. And at that point, they introduce a bill by the deadline in February of 2026. And they start to make any changes to our statutory language that falls underneath our Nurse Practice Act that needs to occur or they would like to occur. And then usually towards the end of that legislative session, they put a date on that. And we're always hoping for 4 years. So hopefully they extend us out another 4 years and our sunset would not be January 1, 2027. We hope then it would be January 1, 2031. Just did the math right there in my head. That was the pause. I apologize for that. And so with that, we always ask for 4 years. We would love for 4 years. When you have to report out all of the stuff that you've accomplished in order to kind of justify the board continuing and having that policy setting abilities, you want to be able to show the stuff that you've accomplished. If it's a 1-year timeline, there's not a whole lot that can be kind of updated and shown. So even with a 4-year timeline, I wish we could have done more, right? And so we're coming up, we're at our 3-year. And so January 1, we'll start our 4th year. And during that time, we will have a sunset hearing. In that hearing, the president of our board, which was just reelected, Dolores Trujillo, she's a direct patient care RN. She will be with me as the executive officer, and we will go in front of the Business and Professions, the Assembly Business Professions Committee and the Senate Business Professions Economic Development Committee, and they will do our joint sunset review. They will ask us questions that they want answered. They will represent various stakeholders and ask questions and seek clarification on that. And it is typically a pretty rigorous hearing. It has gone for several hours in the past, and I fully expect it to be very similar this time through. A bill is amended and updated throughout the legislative session based on our report, based on our responses to report, and based on our sunset hearings. And then our board will take a position on whether they support with amends, oppose, etc. Never recommend opposing our own sunrise or sunset bill, but you know, strange things have occurred. But we hope that through that process, we get a lot of stakeholder engagement. We hear from the public. We are able to make statutory updates that will allow us to continue to serve California better. So at that point, we did have a sunset bill not pass previously. I believe it was in about 2010. If I remember correctly. It went all the way through, it passed the legislature, it went to the governor, and the governor had to veto it because there was an error in the bill. The governor cannot veto a single section, so they have to veto the entire bill. So at that point, the board ceased to exist until another bill was introduced the next legislative session, where it had an urgency clause, and they were able to reestablish the 9-member board and move forward. There was a lot of confusion around that time with the public wondering if they'd still be able to be licensed, if enforcement would still be able to happen. And yes, it absolutely can. During that time period, we went underneath the direction of the Department of Consumer Affairs, and you kind of fall into the role of a bureau at that point. And the difference between the board and the bureau is they don't have that 9-member policy setting board that oversees it. So the day-to-day functions of the BRN with licensing, enforcement, et cetera, would continue even if the legislature didn't pick up and decide to extend the 9-member board that is the policy setting board. One thing that would change really quick would be the executive officer. So I am appointed by that 9-member board. So if that 9-member board sunsets, my role does too at that point. So there would be a change that would have to occur quickly. With the current executive officer role, it is required that you be an RN, so you be a licensee. I am an RN. I am a licensee of our California board. And that may not be the case if we were to sunset and it would become a bureau. There could be new requirements made, and that could be eliminating that an RN license is required. So at this point, if you have any questions or comments, please let me know. I will do my best to answer it.
Do you anticipate any problems, or is there anything we can do to help?
You know, I never anticipate problems, right? So we do anticipate a lot of feedback. And typically when we get that feedback, it comes from kind of a mass solicitation where they want you guys to reach out to your representatives. within the legislature and say, this is what the BRN does well, and this is what the BRN does not do well. These are the changes that we would like to see, and you let them know. Based on that information, the author then chooses what they want to put into the bill. Now, there have been times in the past where there's language introduced into our bill and our board does not support that language. Then our board sees that as a problem, right? Because they are then have language in front of them that they don't agree with, and so they make a motion to support with amendments, and those amendments would be to correct that language or remove that language. So that does happen. That's a very routine process of a legislative session. So I don't see that as a problem per se. Usually with collaboration, education, we're able to land on something that is palatable by the end. Even if it's not something that our board agrees with 100%. And that's okay, because we are here to serve the California public, and so that input is necessary. And I've only seen positive things come from the prior sunset processes. So in that kind of continued thought process, I think it'll be another good sunset session. I think the hearing will give us opportunity to kind of share all the stuff that we've done and request things that we think would be beneficial, and provide education towards some of the items that are requested that maybe our board wouldn't agree with 100%. And so I don't think it would be problematic, but Alyssa, is anything you want to do is always come out and support. Let us know. Give us feedback, and you know, if you have a chance, come to our board meetings. If you don't have a chance to, and our board meetings are presented virtually as well. And if you don't, watch them so that you can see what our boards and our committees feel about the sunset bill as it goes through the process. Be sure to reach out if you have any information, and just make your voices heard. We want to learn from you guys.
Thank you.
You're welcome.
Loretta, you mentioned that in 2010 there was an error that the governor had to veto.
Correct.
Since then, have you guys put in some mitigating strategies to make sure that doesn't happen with this sunset review?
No. I mean, there's really nothing,
Okay.
right? Because when you think about it, the legislative staffers that are involved, the author, which is it was I don't know if it was Assembly or Senate at that point, believed that everything was accurate, and we, as our board and staff involved, believed everything was accurate. And so it was only when it got to the governor's level that he was like, wait, this is actually something that we can't do. And so they did have to veto at that point. But, you know, we all work collaboratively to try to ensure that everything that goes through is as accurate as possible. There are many, many different eyes on the bill as it moves through the process. There's legal involved as well, in various stages of that process too. And sometimes it's missed completely. Just like the same thing you see that occurs with bills that get passed that have unintended consequences. You just have to, at that point, go into the next legislative session and try to address any of those unintended consequences. And so that would be the same thing we would do here, is if for some reason, which it hasn't happened since then, and it hadn't happened prior to that, it ever shows up in a future bill, we would just go through that same process, and we would just reintroduce, have hopefully a member would reintroduce a bill in that February after that January deadline of implementation, and we can get an urgency clause to get it moved through. And I know, oh, there you go, you're back on. So Carrie, you had dropped off camera for me for a moment, but you're back on.
Yeah,
so
I had to sneeze. I didn't want to do it on camera. Sorry.
Love it. Fantastic. So any questions or comments or anything at that point from you guys? We're going to answer everything.
I was just going to say that Bagley Keene does not have a sneezing exception. I'm sorry. It's technically a requirement for our advisory members to stay on.
I love that. I knew you were going to say something about that, Reza. Fantastic.
Can we
Okay.
request permission?
Well, actually, it's only technical difficulties that are
Okay,
even.
right.
Right? I'm really about to blow my
Yeah.
nose technically right now that I've sneezed.
Now, Carrie, just
I'll
say
wait.
that your sneeze was a technical difficulty and you
Right,
will
yes.
voluntarily have a pass.
Yes.
I'm not encouraging lying, sorry.
I was also just going to add for the record that I was not board counsel back when the board accidentally got sunset due to some error slipping through.
And I was not EO then as well, so Rez and I are gonna just make sure to save face on that one for us.
So we expect a lot of you, Reza.
Yes.
I'll do my best. Keep the board alive.
Thank you, I appreciate that, because that keeps my job alive too, Reza, so I second that 100%. So with that, guys, this is just information only. We don't have to do a vote, but I do want to call attention something that my assistant executive officer pointed out to me that I completely missed. Is in the last agenda item on 8.0, when we did the report out, that Marilyn, you agreed to join the public engagement and website, which we would need a motion and a second, and then go out to public comment on that. And then we would have to do a roll call vote. So that is my mistake completely. Thank you, Yvonne, for catching that and calling that out to my attention. So once we close out 9.0 and go to public comment, I am asking for permission, go back to 8.0 and finalize that item.
Okay.
Thank you. So at this point only, 9.0 is information only. BRN moderator will go out to public comment for 9.0, please.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Lightcap, there are no public requests for comments on the WebEx/Slido. We have no in-person representation in BRN HQ. Would you like me to close this window?
Yes, thanks.
So we've
Right.
gone back to 8.0. Thank you for that. And so right now for Marilyn Ababio to be part of the public engagement and website subcommittee, we do need a motion, a second, public comment, and a vote, and we'll be able to wrap that one up. Apologize for missing that. Thank you.
Motion to accept Marilyn on the public engagement subcommittee.
I second.
Okay, board
Alyssa.
moderator, if we can go out to public comment, please, for Marilyn being appointed to the public engagement and website subcommittee.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Lightcap, there are no public requests for comments on the WebEx. We have no in-person representation in BRN HQ. Would you like me to close this window?
Yes, thanks. Okay, now we can do a roll call vote.
Yes, please. Thank you.
Lisa?
Just confirming the roll call vote as next step.
Yes.
Okay. Carrie?
Yes.
Marilyn?
Yes.
Elizabeth?
Yes.
Okay, and me, yes. All right, moving on to item 10.0, information only, presentation from the California Association of Clinical Nurse Specialists on future priorities for CNSs. And Alyssa, do you want to introduce our speaker?
Sure. I'm honored to introduce Mary Lawson Nichols, who is the president of California Association of CNSs. Mary? You're there.
Mary,
I
you
think
should be able to come on camera and unmute yourself.
Yes, it takes a little bit to let me come on. Thank you so
There you
much,
are.
Alyssa, and thank you so much for allowing me to go ahead and give an update from the California Association of Clinical Nurse Specialists. On July 12th, this CACNS, which is our California Association Clinical Nurse Specialist, hosted a 3-hour webinar on the importance of the CNS voice in California. This event actually aimed to educate and empower California clinical nurse specialists and other attendees on how effectively to engage with their state assembly person and Senate representative. One of the things I noticed in your group in showing the map, we're kind of like a desert here. You can see every state around us has some type of privilege except for us. And really, we wanted to go ahead and highlight how critical the CNS plays in shaping healthcare policy and advancing the nursing profession within our state. Our presenters actually was myself and members of the legislative group that Alyssa co-chairs, our regulatory and advocacy group, which we have another CNS that co-chairs, that was part of our presenting group. And then we also have an organization lobbyist who's been actively working with us as we're going through the process of having a bill that could actually help us have full practice authority. You know, in that presentation, it was shared that we started this process in 2024, and CACNS has formally launched its initiative to secure practice authority for CNSs in California, and we're still going strong. This milestone effort seeks to enable CNSs who are licensed by the California Board of Registered Nursing and those that hold a master's and doctor's degree to practice to our full extent of our education and training. Now, within our presentation on July 12th, the speakers, we really discussed how full practice authority would enhance interdisciplinary collaboration, improve care coordination, and increase access to timely treatment and to lead to better patient outcomes with looking at expanding our practice. We also emphasize that we can go ahead and potentially help to reduce hospital wait times, lower infection rates and complication rates, and support early intervention efforts. The webinar included interactive breakout session, which we thought was fun, which we had a role play on how you could go ahead and have this discussion with your legislator. And what was fun was we actually role played making sure that you keep it short and sweet and not go ahead and ramble on, as their time is very precious. We also actually practiced in this session how to write a letter. We had active participants leading people from throughout California. We had a northern area, Central California, Southern California, San Diego, that actually helped to mentor people to write actual letters at that time and to help them send it out to their representative. With that, we concluded with a very educational dynamic question and answer segment. And we really wanted to go ahead and make sure people left knowing what is the next step and what can we do with this advocacy campaign. I really want to highlight and really thank Alyssa and Pamela Jane Nye, our president-elect, Alina Sletlaw, and our lobbyist, Roxanne Gould, who really helped to shape this program. Are there any questions?
Yes, thank you so much, Mary. I saw the email that went out and I was so looking forward to joining, but I unfortunately had a prior engagement, so I wasn't able to. Were you guys able to record that webinar at all? And so is it available?
So it's funny you should ask. We did record. We're trying to get it up on the CACNS website. We had some logistical items, but the goal is possibly within probably the end of September. And then also too, we're going to have a repeat of this session, but a mini session in October. And it won't be a weekend. It'll be during the week, hour and a half. And we're going to cover some of the same items, have some of the same interactive topics, and actually show them show whoever attends how to write these letters as well. We also had created within the legislative group a kind of a template that actually we gave out to people on how they can do that. So if they didn't remember, they have something they can refer back to with helpful links and tips and tricks.
That is wonderful. Thank you so much for your leadership in CACNS and all that CACNS is doing. So, awesome.
Thank you.
This is Marilyn Ababio. May I ask a question?
Absolutely.
Thank you. Thank you for that succinct report. I appreciated it. I'm playing catch up here. This is my first year on the board, on the committee, and I want to just be sure of my understanding. Does this, when you mention the phrase full practice authority, is that the same thing as was discussed earlier, where CNS would be granted the ability to have an independent practice as well as prescribing authority?
We're looking for the full practice to the extent of our education. So independent practice, prescriptive authority. This is actually what our education has taught us, and really in California we are hampered and we're not able to go ahead and practice to the full extent, and that's what we're looking to do as we go into the 2026 and beyond.
So that caveat that you use with respect to education, does that mean that that the licensed nurse, if he or she has I don't know if you can get licensed without uh, um, um, without an undergraduate degree, but then we have graduate degreed nurses as well as, and then those nurses who are, I guess, near PhD level. So is the hope that all three of these categories of nurses would have this full practice authority?
No, it would have to be based upon the schooling, and also the state has already set what is a CNS. So they have to be a master's or a doctorate prepared nurse. And this is actually set by the state of California. So it couldn't be a bachelor prepared nurse. It has to actually be an accredited program that the state of California recognizes.
I understand. Thank you very much.
Absolutely.
Thank you. So I'll just jump in here. Great presentation. Thank you for that.
Thank you.
Some of the
Thank you,
things
Mary.
that-
Let me
Thank you.
just add that it's, it's not just prescribing like medications, it's being able to order things without, do our assessment. We know that something is needed and we have to wait for a doctor's order now. And that could be Monday when we're working on trying to help the patient on Friday. So it just speeds up, in a timely manner, patients get what they need. And we're well prepared to do that. It's just that we're not able to do it right now in California.
That is accurate. So going back to kind of what we talked about earlier is in California during the meeting minutes discussion, the current scope of practice is that of an RN. So it is for the clinical nurse specialists, they do not have an advanced practice RN scope of practice. They have an advanced practice title, they are recognized as advanced practice, and they do have the education and training of an advanced practice nurse. Within the law, which is our Nurse Practice Act, they do not have any kind of expanded scope of practice. So with what Mary presented here, it was great presentation and it shows where that focus needs to go. So when you look at the role of the Board of Registered Nursing, the role of the Board of Registered Nursing is that of public protection, not of promotion of the profession. So you guys could come to our board and say, hey, we want full practice authority, and we could hear you on it, but there's not much that we can do about that, right? It does have to happen at the legislative level. And that is where your organization, the California Association, the National Association, they have lobbyists, they go out and they can meet with legislative members that may choose to write a bill that changes that process in California. Our board does not have any input on that process until a bill is introduced. When that bill is introduced, it would go in front of our 9-member board. We would notice it, it would be in part of the materials, and there would be a discussion and a vote on that. Our board could, I'm not saying it would, but our board could at that point say, in the interest of public protection, we don't support this. It's always a possibility. I have to put it out there. But our board could also say, in the interest of public protection, we do support this. And so that would be the role that our board would play if that were to be a bill that was introduced and carried through and presented to our board members. Historically, our board has not opposed any scope of practice bill that has been brought in front of us for APRNs. So that is something that our board has been in support of. There has been evidence around it that supports that it is safe and it is not in any kind of a concern for us with public safety, which is what our role again is. But I do always have to put out that there is a possibility to really define that separation of public protection and promotion of the profession, that we could oppose it if we thought that there was some kind of an issue. The conversation around ordering and prescribing and stuff right now, the 2 APRNs that have that authority is our nurse practitioner and our nurse midwife. And there is a bill that is currently moving through the legislative session right now for CRNAs that would provide some clarification around their scope of practice as well. So California is moving and changing, and we are interested to see how things happen in the future. I love that your focus is appropriately placed and you're not asking our board to do anything. So I appreciate that. And I love that you're going the route that you're going for that. So thank you for the update. And if you guys have any questions as well, we'll open it back up for questions here, but if not, we'll go out to public comment. No questions here, board moderator.
Thank you, Mary.
Open it to public
Absolutely.
comment. And Mary, stay on in case there is a public commenter that would like to be answered or addressed by you.
I have the time. Thank you so much for allowing me to stay on.
Thank you.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, I would like to make a comment. Please remember you will have 2 minutes to make your comments. I would like to give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment.
As we're awaiting public comment, Jessica, I would like to ask if we could reorder and take agenda item 12 before agenda item 11, just because we're pushing up against our timeline and the regulation discussion might be pretty robust. So that way we can address 12.
Committee Chair Lightcap, there are no public requests for comments on the WebEx. We have no in-person representation in BRN HQ. Would you like me to close this window?
Sure, thanks. Okay, and moving on to item number 12.0, information only, data on final dispositions of disciplinary cases against CNSs.
Thank you. And Mary, appreciate your participation. We will bump you back down to an attendee at this point. Feel free to come into public comments if you have any further need or desire to interact with us.
Thank you so much.
You're welcome. Thank you. Okay, agenda item 12, you'll see that in the material starting on page 27. There is a timeline provided from 2018 to current as of August 13th, 2025. It does show the discipline statistics for our clinical nurse specialists. You can see that the numbers remain very small. And in areas where there is a violation of our Nurse Practice Act. The one thing that you don't see yet, which we will be updating for future meeting materials, is what we wanted to show was the growth of our licensee population. And so year to year, we see more and more CNSs. And even as we're seeing more and more CNSs come into practice, your discipline numbers still remain low. So what I would like to have demonstrated in these tables, because these are the same tables that are presented out at every one of our advanced practice advisory committees, is show that in a percentage. There was some comment that we had received from the public that says, you know, on some of the other APRN data that it looked like the discipline cases were going up. And we couldn't accurately respond to that because we didn't know if it was just because there was an increase in licensees, right? So if you have one licensee and you have one discipline case, then it's 100%, right? But if you have one licensee and you have 100, you have 100 licensees in one disciplinary case, that's a whole different number. And so right now we're giving you the number of disciplinary cases. What we failed to do is give you the number of the licensees to correlate with that. So we do plan for our next APRN committee to have that updated with the number of licensees for each one of these years. So any questions on this that you guys have? If not, we can treat this again as information only and go back out to public comment.
Loretta, can you just explain what those types of discipline are? Like, what does it mean for public approval, or, you know?
And watch how I'm going to defer to this right to Reza, because Reza has the correct terminology and will do a much better job at trying to explain that, and I will stumble over it.
I'll do my best. So on the meeting materials, there's two charts under this section. The first one is the one that mentions public reproval, probation, surrender, etc. The second chart talks about violation types. So the first one up, a public reproval is kind of the lowest level of discipline that we can impose in a formal discipline case. Lower than that would be a citation, which doesn't go through the formal discipline route. It's kind of an administrative thing that's a little different. But when an accusation is filed against a nurse, including a CNS, a public reproval is kind of the lowest level outcome, short of dismissing the accusation entirely. And then probation, of course, is what it sounds. The license would be on probation for usually 3 years, but it can vary. And there would be terms associated with that, including reporting to the BRN as, you know, as required. Your employer would have to be aware of your probation, and you'd have to have a worksite monitor. and things like that. And depending on the nature of the violation, there could be terms that are kind of tailored to it. Surrender is, again, is what it sounds like. Once an accusation is filed against a nurse, they could choose to surrender their license instead of going through the hearing process and contesting it. A surrender in that context is considered a disciplinary action. Voluntary surrender during probation, same thing, except that it would occur after a probationary order is effective, and in that situation, same thing. A surrender is considered a disciplinary outcome. A revocation, again, that's kind of the harshest discipline we can impose. They can seek reinstatement after a period of 3 years or a lesser amount of time if the board chooses to impose a shorter period of time. And then reinstatement, I'm not sure how that kind of ties into the discipline chart.
A certain amount of time, they're able to petition for reinstatement, and they would get their license back.
Right.
Potentially after review.
Ever had anybody petition for reinstatement according to this chart?
Correct. Usually when you have a discipline enough that suspends your license, the revocation, right? You only see there's 3 total revocations in the past almost 7 years. Those would be the ones that would request for reinstatement. Additionally, those that surrender or surrender during probation, those are typically a voluntary thing. And so they've chosen to do that, right? And so they usually don't go back on that. So truly, you would see the ones that for the revocation, that they would be like, I want to reinstate, because that was not their choice, right? And so we would see that. Usually at that point, if you've gone through the revocation process, that is public, it is on your license. Many people do not choose to reinstate, as that is a permanent part of your kind of license history.
With that said, though, the reinstatement process is, it's a formal process. If somebody files a petition for reinstatement, it goes through a similar hearing process that's presided over by an administrative law judge that will issue a proposed decision on whether to grant the reinstatement. A reinstatement can be granted just flat out with a full unrestricted license, or it can be granted with probation. And yeah, so I just wanted to emphasize it's as Lori said, they might have chosen to go a different path or something, but it is definitely a pathway back into nursing that many nurses do utilize and seek to show that they've rehabilitated themselves for whatever the issue was and do come back to nursing successfully. So yeah, and then looking at the chart, the second chart, real quickly, I have a little less interpretation on each of these, but a little clarification as far as I can understand them on the violation type chart. So a practice, that first line, practice related violation is anything that the nurse or CNS did in the course and scope of delivering nursing services. So, something where maybe a patient was harmed or doesn't necessarily require harm, but a breach of the standard of care in delivering practice-related services. 801 practice.
Insurance malpractice related.
Yeah, so under Business Professions Code section 801 and the following sections, there are requirements to report to the BRN whenever there's like a insurance payout or a settlement above a certain dollar threshold. So when we receive information about an incident through that route, I guess it's categorized under that 801 practice category if there is ultimately discipline action. OSD, that next line.
Out of state discipline.
Yes, discipline by another board of nursing. So, you know, that's an independent cause for discipline here. I suppose, I don't know this for sure, but I suppose that could include practice related issues, or it could include substance issues, or whatever it may be that another state disciplined them for. I presume would fall under this OSD category. So there might be a little bit of, you know, overlap and just, you know, fuzziness with these numbers just based on that overlap that could occur with like out of state discipline, you know, a case falling under that when it was really a practice issue or a substance use issue. So the next line, conviction, pretty self-explanatory. If somebody gets a conviction here for, it could be a variety of things that would have some kind of bearing on their safeness to practice nursing. And then SUD is substance use disorder. And then sexual misconduct is what it sounds like. And I don't know, you know, what examples to give you for what would fall under other, but that's a maybe not so quick rundown of it, but the best I could do, unless there's any questions.
Reza, I appreciate that. That was fantastic.
Sure.
I would have done much worse. So thank you. Thank you for doing that. And I just have to do a shout out. I did a quick message out to my team that said OSD ? And they were able to come back with that. So I was like, I have not used that before. So thank you guys for helping us out with that. So any questions or comments on this? It is information only. So at this point, if there is no further questions or comments from our committee, we can go out to public comment. Thank you. Board moderator, can you go out to public comment, please?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate if they would like to make a comment by typing into the question box, I would like to make a comment. Please remember you will have 2 minutes to make your comments. When I give a reminder as your time approaches, I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. Committee Chair Lightcap, there are no public requests for comments on the WebEx. We have no in-person representation in BRN HQ. Would you like me to close this window?
Yes, thanks. All right, and then let's move back to item number 11.0, discussion and possible action regarding proposed draft regulatory language for CNSs, including but not limited to definitions, application process, and education oversight.
Thank you. So I'm going to apologize in advance. I did not get materials up, but I will have materials posted quickly. We do have the ability to post materials within a big 24 hours of the meeting. I apologize. That was completely my oversight. I will kind of go through some of the conversations around the draft regulation process first before we actually go into language. If we get to a point, I will share the language that was submitted by the regulation group, and we'll let you guys kind of speak on that. But as the language was presented to me to start the review process, I do work with our chief of ledge, who is on maternity leave at this point, but will be returning soon. And then once it goes through our review, based on your guys' feedback, we do move it up through a legal review. And then it goes to DCA's regulatory attorney. The one that assigned to us is Stephen Vaughn, and he does a review. That review that he does is he takes a look at the language that we proposed, and it tries to connect it back to the statutory language that is granted to us through the legislator to see if we have authority, right? You cannot, regulation is used most often to clarify statute, but it cannot create new law essentially, or or expand statute in a way. So it is usually used to kind of establish a process based on the statute, or provide some clarification around it. So he does that check for us. Additionally, because he's not directly involved with the BRN, he asked the question, what does this mean? Because a lot of times we're so caught up in our scope of practice, working with subject matter experts, et cetera, that we fail to identify the obvious. And so they come in to ask the questions of the obvious. So once that is done, and it goes to our Director Kirkmeyer from Department of Consumer Affairs, they do a review, and then it goes to agency, and that's the agency that sits above the Department of Consumer Affairs. And once that is accepted, we have to go ahead to move it towards the Office of Administrative Law, or OAL. Once it is with OAL, that regulatory process begins, and with that next phase, and that's where we put out a notice to the public. The public has a limited time to make comments, to suggest changes. We are then required by law to respond to every single comment that is received, whether it's in support or opposition, or if it's just as, I think this would be great if BRN did this. Okay, fantastic. We respond to every single one of them. If our board, after receiving those comments, decides to change the language, the regulatory language, they can, and they make an update, and that goes back out to public comment. Depending on whether that's a sensitive update, or if it's just kind of language, adding a period, resequencing, such, depends on the amount of time it goes back out to public comment. And we can get caught up in that loop for a long period of time. The best case scenario is it moves through quickly, and Office of Administrative Law receives it, they review it and says everything is clear. You have statutory authority to support everything that you've asked, and they approve it, and we're able to implement it. Another option can happen at the Office of Administrative Law, where they say you're not quite there, but I see that you're making progress. You might want to withdraw the package and resubmit at a later time, so you don't have a failed package. That is an option as well. So, kind of worst case scenario for us that occurs is if a lawsuit is filed that says they don't believe that we're doing the correct action, and they stop the progress of us putting forward regulations at that point. So it is not something that the BRN has complete control over. So it does go through many, many layers of review, a lot of input from the public. Yeah, but we start here, right? We're working with our subject matter experts. And so some of the questions that pose to me when I'm looking at this, and just to kudos to the team, is really a discussion that needs to be around clinical nurse specialist education, right? On whether or not regulations need to be put forward for the BRN to oversee and regulate CNS regulation. There are nurse practitioners did move forward with the BRN overseeing their nurse practitioner programs in the state of California. It also allows for nurse practitioners that are enrolled in out-of-state programs to do clinicals in California, as long as they meet some certain criteria. That's all outlined in our nurse practitioner regulations. So before we can move forward with any kind of regulatory language, I would love to get the input from the team here that what your thoughts are on the regulation of academic programs offering clinical nurse specialist programs in our state. I will pause for a minute, let that kind of sink in, and then I'll explain some of the pathways as to why this is important. So with our current laws, the way that they are written, we allow for licensure in California to be obtained as an advanced practice RN without the requirement of national board certification. We are the only state in the nation that requires that. That is in opposition of the APRN consensus model. The APRN consensus model says we should have national certification for all APRN licensees. Our board did vote to align with the APRN consensus model many, many years ago. So it would seem to me that we would want to require national certification for licensure. However, we have many people that graduates, so I'll specify. We have graduates that want to begin working as a CNS immediately upon graduation. That is something they've been able to do historically here. That would not be the case if we required national certification for licensure. That could potentially be done one of two ways. If we require national certification for licensure, we write that in on the application process. We see if we have statutory authority to support that. We may or may not. I won't know that affirmatively until our DCA regulatory attorney takes a look, right? That's that second step where they go and they kind of work with us and say, do you actually have an ability to write that section in? We may not. It depends on interpretation, right? It says we could set the licensing standards. That may be setting the standard of national certification requirement. That pathway was just recently removed from another state, the final state, except for us, for national certification. What Kentucky or Kansas did, so Kansas, I believe, was the last state. What they did was allow for a temporary CNS license on graduation or completion of an accredited program, and gave that person 6 months to obtain national certification. If they failed the national certification 2 times, they would not be able to continue that license, having that advanced practice license. If within that 6 months they passed their national board, they were able to continue and be licensed as that. That is a possibility we could potentially again put forward, but again, always checking to see if we have statutory authority for that. It may be determined that we have no statutory authority for that and it has to go through the legislative process. And that would be the path that we would let organizations and stuff know about, and they could pursue if they chose to. Some of the reasons that I put that kind of clear delineation out is that directly relates to us approving these CNS programs. Currently, our CNS programs come through an application process called Method 1. Method 1 means you complete a board-approved CNS program in California, and you can obtain licensure without national certification. Method 2 is you can receive licensure through national certification. That is not offered to any out-of-state CNS program. It is only offered to in-state CNS programs. Currently, we only have a process to do an initial review of a program in our state. We do not do an ongoing review. We do not do any kind of routine continuing approval visits. We don't monitor the faculty. We don't monitor programmatic outcomes, any of that stuff, right? So this is a clear kind of spotlight on, we need to address this because it's not something that we have clearly defined as a process for license. We don't have a clearly defined process for reviewing our schools. And so that is why coming to this group, we need to ask the question, what you guys think is the best path forward. Now, I met with the National Council of State Boards of Nursing. They, of course, are the authors of the APRN consensus model. They recommend national certification. They additionally recommend that we do have some oversight of our schools. And not necessarily to the extent that our oversight is of nurse practitioners. But in conversations, there was talk about tracking programmatic outcomes as being something that would be beneficial. And that is looking at making our California programs accountable for their national certification pass rates. Because that is the only way that you're licensed in every other state but California. Additionally, when you guys are looking at potentially moving to an independent practice, CMS requires national certification in order to bill for your services. And so there's another reason why we could support national certification. So it would make sense that when we're looking at academic institutions that offer CNS programs, that you would want them to be licensed. You would want them to then be able to be licensed through the national certification pass rate process. And we would want to make sure that that stays at a consistently high passage rate. The other ones that they talked about was tracking growth of the program, whether or not they have resources to support the growth, faculty to support the growth, that they're able to continue to provide the program as promised from admission to graduation or completion of the program. The other one that was talked about is in our nurse practitioner education programs, the standards require a specific amount of direct patient care. That direct patient care cannot be done through simulation, standardized patients, et cetera. They have to do that in direct patient care. It does not mean that they don't do standardized patients. They do that above that minimum requirement of the direct patient care. So those are some of the conversations around education that need to be discussed in this committee before we know how to move forward with our regulations. One of the other things that I wanted to share was a 2020 study that was done by the National Council of State Boards of Nursing that looked at pre-licensure education. So this is your basic RN education. And I can't say that it's 100% transferable to APRN education, but I wanted to kind of share some of the things that was put out through that. And they talk about quality indicators. And that to me is something that we look at as a board in whole, right? And they had 18 quality indicators. That was evidence-based curriculum that emphasizes quality and safety standards for patient care. 2 is evidence-based curriculum that emphasizes critical thinking and clinical reasoning skills. 3 is faculty are able to role model professional behaviors. 4, clinical experience with actual patients that prepare students for the reality of clinical practice. 5 is systematic process in place to address and remediate student practice errors. 6, faculty teaching clinical courses demonstrate current clinical competence. 7, consistent administrative leadership in the nursing program. 8 is collaboration between education and practice to enhance readiness for practice. 9 is ongoing systematic evaluation of the nursing program. 10 is institutional administrative support of the nursing program. 11 is consistently has a pattern of NCLEX pass rates that meet set standards. 12 is administrative support for ongoing faculty development. 13 is the significant opportunities for a variety of clinical experience with diverse populations. 14 is consistent full-time faculty as opposed to reliance on adjunct faculty. 15 is quality simulation is used to augment the clinical experiences. 16 is comprehensive student support services. 17 is national nursing accreditation. And 18 is admission criteria that emphasizes a background in the sciences. So obviously those are not everything that transfers over to APRN, right? So instead of NCLEX pass rates, you guys would look at national board certification pass rates. Instead of looking at admission criteria that emphasize the background in sciences, you would say, you know, is there a similar type of admission criteria? You know, so when I look at the nurse practitioner regulations, which is 16 CCR 1484, they say a faculty member must be this type of prepared, and they must be working as a nurse practitioner, and they must be licensed as such, and all this kind of things, right? And in order for a nurse practitioner education program to be approved, they must have national accreditation, right? So there's some where we can pull some similarities out, but you may, if you choose to look at requirement for board national certification, national board certification, and you choose to have some type of oversight of the academic institution, that you could balance that, where we basically track outcomes, look at quality indicators, or warning signs, because they did have another set of like 11 warning signs. And, you know, as something, and not go the route that we have currently in place for the nurse practitioners. So I just wanted to kind of throw that out there. If you would like me to cover the 11 warning signs that they've identified, I'm totally willing to do that. I will put this in the materials as well, but I can pause at this moment because we are running up against time for really just kind of what you guys would like to see education wise, because that will determine our path forward on regulations. And then we'll be able to present regulatory language with the academic side worked out when we bring it forward.
So that was a lot of information.
Yes, it is.
Let me see if I got this in my head correctly. So we have a couple of pathways. One would be going that like kind of method one where BRN has to have complete oversight of the educational programs, right?
Correct.
Two would be just require like no oversight of the programs, but requiring national certification. And three would kind of be a hybrid.
Potentially. So the one is correct. There is no 2 or 3 next. It's however you guys recommend moving forward. Is would you want to defer to accreditation? That is what our CRNAs do. CRNAs defer to accreditation. We do no oversight of their educational programs. Nurse practitioners, we do oversight of the program and require national certification. Their oversight goes into very specific requirements. You could follow that same path and adopt that, or you could look at maybe adjusting that oversight to be more focused on tracking and reporting of quality indicators and warning signs, and less on specific kind of academic running of the program, and defer that to the accreditors.
Well, you know, this is Alyssa. I know we've discussed this ad nauseum, I guess. It's like, you know, they're also different, you know, as much alike as we are. The process and how we get there is different, although the education is similar. But one of the problems with CNS is that we don't have the luxury of a lot of national certification exams available. And so they were at one time, but aren't now. And so, you know, if we only required that, we'd have a problem. The CRNAs have their own organization that does all of that, right? So they don't have to worry about anyone else. The nurse practitioners as well. And they also have the American Credentialing Center. For those of you who don't know, but I think you do, but I don't know that new members, Marilyn, I don't know if you know, but we've tried to work with the Credentialing Center to bring back some national certification methods for CNSs because they dropped a lot of them. And it's been a lifelong process. I've been involved in a number of us, and it's very hard to get there. So if we required it, we would be leaving out a lot of people who appeared at CNSs but can't take an exam to show that they're,
Clarification.
qualified.
Yes, for
I don't know.
clarification on that, Alyssa, if you were educated in a population focus that had a previous national certification,
Right,
does
right.
not address that. You would continue in that. That is not it.
Right.
Currently, if you are only able to educate if they can be licensed, and licensure is required to have national board certification. So we do not in California even support any CNS role preparation outside of the board certified national certifications. They can do that as a secondary. So for an example, women's health nurse, clinical nurse specialist, the programs that used to offer that stopped offering that. They only offer an adult GERI CNS now, and the women's health preparation is done as a subsection, essentially. So your preparation is actually done as an adult GERI CNS. That's the one that you can get nationally board certified in. And then it would be a subspecialty in the women's health arena, which we have no regulatory authority over at this point because it is not done. So
Yeah.
licensure right now is limited to the population focus that does have a national certification. It wouldn't change that. Just continue that. I know we're over time, so I want to just kind of continue to have this conversation. If you guys are allowed to continue, maybe 5 or 10 minutes and we'll wrap this
Okay.
up.
Yeah, see, I guess from my perspective, and I understand your perspective, Elisa, I don't see how it would necessarily hinder people, right? Because we do have the ANCC and the ACCN accrediting bodies that we can take our national certifications from, right? And they cover basically the lifespan, right? Neonate, peds, adult GERI. To Loretta's point, we can have subspecialties there, and if we're following the consensus group model and like the LACE framework, right, which suggests national certification, also instituting a grandfathering clause, right? So for those who, like yourself, have the psych mental health, like you would still be able to continue with your license, right? Because you'd be grandfathered in.
Right.
So I don't necessarily see how requiring national certification would hinder our
It would
population, unless
I
anybody
know
else
this is
also.
very it is a very controversial subject, and I get that, but I want to put out one more thing. The federal government does not allow for academic institutions to offer education in a role that requires licensing that cannot obtain licensing.
Right.
So there is no hindrance, because as it is right now, if the requirement in all other 49 states require national certification, your academic program must support that, and they must be able to sit for national board certification on graduation. That is already a must. We would just be removing our ability to get that prior to board certification, right? So it's not changing the specialty preparation. Those population focuses are in alignment with the consensus model. It does not currently support women's health. It does not currently support psychiatric mental health. That is a prior one that is graduated, grandfathered in, but it is limited to date as that as well. We cannot have a program in California that says, I offer a women's health CNS only, and I want them to be licensed through method 1. They can't. They have to do the adult GERI and then do the women's health subspecialty. So the same thing with the psychiatric mental health nurse, clinical nurse specialist. we cannot have a program in California that offers a psychiatric mental health nurse CNS preparation that doesn't tie that to the original population focus of potentially adult GERA.
Yeah. And you know, I'll just voice my opinion again, but it's sad because the consensus model says that one of the population focus was psych mental health.
Yes.
So yeah.
Yeah. And it
I
is.
guess-
And we love when nursing programs do offer those too, but they do have to offer it as a subspecialty currently
Right.
because of the
Right.
requirement for national certification for licensure. So
Sure.
support our programs in offering that, but they have to offer the adult cherry first because that's the only path to licensure.
I'd like to make one comment if I can. So I liked what you mentioned about potentially doing a temporary licensure when they're awaiting to take national certification. That was very similar to the RN boards in Pennsylvania. And that was great because you could start working right away and like help pay for those national certification boards. And so, yeah, I think that that's a really nice option to look into for the group that's doing that.
We could look into that, you know, and again, it all comes back to whether or not we believe we have statutory authority and others agree. And so the process we have in place right now for RN licensure is that we give them an interim permit for 6 months while they are working to pass NCLEX. If they fail NCLEX, that interim permit is removed effective immediately. If they pass, they receive their licensure. And so that is a process that we could look at writing in to see if that is possible. We would not do a temporary license. The temporary license is already defined in our statute, and that is different. That is for nurses endorsing in who already hold a similar license out of state. So this would have to be a different pathway that would be developed for licensure. I'm happy to look into that and meet with the regulatory team subcommittee to discuss what our findings are. And I can move forward with that. What I do want to get some additional direction on to work on future regulatory language with the regulatory subcommittee is that of oversight of the academic program. I think that is a big thing that we need to kind of finalize. If we can do that, just get your thoughts on it. That will help us with the writing of the regs.
Yeah.
I think my thought would be just to go for national cert. That's my thought.
I hear you on that. With meeting with the National Council of State Boards of Nursing, they recommend more oversight than just relying on the accreditors. Accreditors are do not have the same focus that a board of nursing has. So board of nursing is on public protection, right? Accreditors are focused on academic preparation, academic excellence, and it has a national focus versus a state-based focus. We would, our board has typically supported a joint venture in that. An example would be with our pre-licensure nursing programs, right? We agree that national accreditation is a wonderful thing, but we do have some public protection that we like to look at from our role as the BRN. And with that public protection that is protecting the student as they enroll into a program, that student is about ready to dedicate 2 or more years of their life to this academic institution to become licensed. They are also going to spend a lot of money, right, with their tuition. And academic preparation is the only thing that you will purchase in life that doesn't have a guaranteed outcome. And tuition can be very, very expensive, right? I can put $10,000, $30,000 on a car and I could sell that car. If it doesn't work out, I can go lemon law or whatever. And, you know, I could change my mind, all that kind of stuff. With education, I can't. I go to a program, I expect to graduate, graduation doesn't lead to licensure, right? Passing your national boards leads to licensure. So having an eye on the pass rates, on completion rates, on graduation rates, on attrition rates, those are all looking at public protection, right? We have heard in the past when it comes to education that if institutions have a difficult time meeting their licensing standards or their certification standards, they start failing people out. Well, then you get a higher attrition rate, but you get a higher pass rate. What you want is low attrition rate, high pass rate, right? So accreditors typically look at it different than our state boards of nursing. And so I would hear you on it. I know that National Council of State Boards of Nursing does not agree. They do agree that some oversight is needed at a state level. And I would just like for you guys to take that into consideration.
What would that, what kind of, I don't know, a burden would it be on the board in terms of taking that on? You know, what resources would you need more resources?
We currently have a group of nursing education consultants that are specifically focused on schools. The more schools we tend to need to have oversight, the workload of them increases, or the need for additional positions increase.
Okay.
That's always a process that we're willing to look at. It could be simple as requiring a reporting structure, kind of like our Bureau of Private Post-Secondary Education. They're required to submit an annual report to them that reports out kind of attrition rates, et cetera. That could be something that we do and that we just simply track them. But we do also have inspection rights with our schools. We are able to go in and inspect our schools if we get a complaint. We are able to go in and inspect our schools on a routine basis. Typically, that's done about every 5 years, or in alignment with their national accrediting body. If the accrediting body says they're good for 8 years, we go in at 8 years with them. That could be something that you guys consider as well in regulations. So nothing needs to be decided today, but any input is appreciated, and I will continue to work with our subcommittee on this.
I would, first, I'd really like to hear if Lizzie has any thoughts on this, just because she was doing like certification stuff too. But personally, having gone through like researching CNS schools and stuff like that, it is really confusing what they offer and how good they are. And I think that if there is some oversight that we can put into these regs, or to help guide those regs, I think that it would be great to be able to even just see passing rates or like the attrition rates, that kind of stuff. That would make it, first of all, like the schools should want to post that stuff and want to be able to recruit more people. Like we want more CNSs in the state. And if they have really low rates, that's something that they might want to reevaluate their program. But that's just my personal thoughts. But I'd love to hear what Lizzie and Marilyn also have to say.
Thanks. I'm all for it. I think that there should be national certification. I know there's nuances, Elisa. I know that. I appreciate that. I hear that. I think there should be national certification, so we're in line with the other professions that have national certification for licensure. I like the way that you explained about the temporary license, Loretta, and then if they pass and on. And it was just like when, you know, the consensus model and that was passed, there were some very unhappy people. However, in time, they realized that it was the best way to go. And we have been dealing with this for so many years, and we're still dealing with it. It's like we have got to get on track here. So I'm all for national certification, following the consensus model and LACE. I'm all for it. So, I mean, I may have a bit of a bias, but I'm all for it. And also the oversight of the education, because Some of those education programs, they're not all created equal. And we see that when CNSs come out and they practice. So I'm all for the oversight of the education as well.
Appreciate that. Marilyn, I think you're the last one to chime in here, and we will try to end at about 3:15 if possible.
Okay, I'll take less than a minute.
No, you could go longer. I said try if possible. So I just want to let people know that we're trying to wrap it up. So be mindful of our
fine.
time.
Well, I am new to this and I listened carefully and I think I hear some pros and cons. So I'm not going to, I'm not going to land either this way or that way. I just feel like I enjoyed the consideration of the benefit of national licensing requirement, but yet I feel sensitive to the investment that the students make and their ability to make a dollar before they have to pass probably what is an arduous test. Some people are not good test takers. So, I abstain from any real,
Let,
sorry.
let me put in a bit of history. When the national certification came out for CNSs, there weren't NPs around, by the way. You had to work for 2 years before you took your exam for certification. So you had to work in the clinical area as a CNS, in doing this stuff, but you could not take it right away. You had to be out there doing it.
Yeah,
Then it
unfortunately,
changed.
the other requirement for the 49 states that you have national certification, and with the increased use of online education, right?
Yeah.
It becomes really hard. If you have somebody that's in Nevada going to a California school, they can't get licensed in their state if they're not prepared for national certification, and they will need to have that before seeking licensure. So those are all things that just kind of pop into my head as kind of thought processes here. Alyssa, I'm happy that you're on our regulatory subcommittee. I really appreciate that. We will need to set up some additional meetings
Okay.
to work on this. But those were some really big questions that I needed to kind of have discussed and thrown
Okay.
out here in this public forum for discussion.
Thank you.
And so that we kind of have a path forward on writing those regs. So just to wrap this up, I will ask to go out to public comment. And then as soon as public comment is over, since we're not making a vote and we're not doing any kind of motion, we will be able to adjourn. We appreciate you guys putting over time with us.
Thank you.
And really just thank you. So at this moment, board moderator, if you can open us up to public comment, please.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for a comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Terry Aries would like to make a comment. 1 second, please.
Okay, hello again, everyone. I want to address the topic of the education within the regulations and just point out a couple of things since I oversee an educational program. You may or may not know that across the country, CNS programs have been in decline for the last 15 years, severely in decline, and have even been in decline in our own state. So I just want to urge the committee to be cautious in how they decide to require, if they decide to require any oversight, because typically any kind of oversight is arduous for a school of nursing to complete. So we are already, most of the master's and doctoral programs across the country are accredited by CCNE, which already has a very robust requirement for reporting for APRN programs, including the postgraduate programs. The other accreditations, as I've looked at them, appear to be less robust in terms of what they actually require. But the more that's written into requirements for the programs over and above what the accreditation already requires, the more difficult time we're going to have keeping CNS programs in California. So I would ask that you look at the least restrictive methodology. I would tell you that we already keep outcome statistics, so that is easy for us to do. But over and above that, it would be quite taxing for us. I have other comments on the regulatory language itself, but it sounds like we're not going there. And since we're out of time, can I send that to someone or just wait for a follow-up meeting?
Send it.
Yeah, you could send it. You can share with Alyssa if you wanted to. You can share it with
Okay.
Macaulay, myself. Macaulay and my contact
Karen.
information is on our web.
Okay, great, thank you.
Thank you for your comment. Mary Lewanson Nichols would like to make a comment. 1 second, please. Oh, maybe not. She left. Maybe she left.
Nope, I'm
Oh
still
no,
here. Can you hear me?
she's still here. Oh, I'm sorry. She wanted to comment and she's in the panelists. I'm sorry. Go ahead, Mary.
No, and I actually Terry had said a little of what I was going to mention, and in the interest of time, I'll just go ahead and leave it with what Terry had said. So thank you so much. I couldn't type and say thank you, Terry, and take myself off. So I apologize. Thank you.
Nice, thank you. Are there any public comment at BRN headquarters?
Hi, we still do not have any public participants, so we do not have any public comments.
Fantastic, thank you.
Uh-huh.
Okay, it looks like public comment has ended. Is that accurate, board moderator?
Correct. Yes.
Wonderful.
There's no more comments.
Okay. So Jessica, if you want to at this point, we can adjourn.
Okay. Item number 13, adjournment.
Thank you, guys.
Thank you,
3:22
Jessica.
Thank you.
today. We've
Thank
adjourned.
you.
Thank you,
Thank you.
guys. for participating.
Thank you, Loretta.
Welcome, Lizzie and Marilyn.
Thank you.
Thank you.
Thank you.
Bye.
Bye.
Thanks, everybody.
Be well, everyone.
Thank you.